Motshweneng. I am a public servant within the district health system, and I'm currently working in the Cape Winelands, and I am also a member of the South African Alliance for the District Health System. It is an absolute pleasure to welcome you to yet another exciting installment of the Salat webinar series, where we will be sharing experiences across provinces and stimulating discussion towards strengthening and positioning the district health system as a steward of quality in the South African health system. Perhaps as a form of introduction, I would like us to step back a bit and actually reflect on the evolution of the quality movement in the South African health system. And I must say at this point that the timeline that you're seeing on your screen is neither exhaustive or perfect. But what we see here is that the quality movement is, in the first instance, at least as old as our democracy itself. And before getting into these events, I think it would be important for us to deal slightly with the terminology first, because I think we can appreciate that norms and standards are defined differently in different contexts, including in South Africa, and the words themselves are sometimes used interchangeably. But I think without being bogged down on the details and the concepts, for the purposes of this discussion, it suffices to think of norms and standards as a set expectations against which healthcare facilities or establishments are assessed and expected to perform. Now, back to the timeline, just trying to get my pointer here. Now, around 1994, Stellenbosch University piloted what they called a standards-based accreditation program using a set of standards. And this program actually ultimately evolved into COSASA, which ran standards-based accreditation in both the public and the private sectors for a number of years. But the turn of the century saw several activities in terms of quality evolution. This includes the establishment of the HQA, which actually conducted clinical quality assessments for several funders in the private sector. And in the public sector, it saw the development of the NDOH's PHC norms and standards. And the idea from here of norms and standards actually evolved, leading into the development of the national core standards, which started in 2018 but were approved in 2011. And later on, it saw the emergence of the ideal clinic, both of which focused on the public sector. Meanwhile, around the same time in the private sector, in some parts of the private sector, there was gravitation towards the ISO, particularly the 2015 version, against which, for example, the Life Healthcare Group was certified for the first time in 2018. But significantly in 2018, the promulgation of the norms and standards regulations was a game changer in that it made a set of standards a legal requirement which was enforceable both in the public and the private sectors. So activities like quality self-assessments by healthcare facilities, the reporting of adverse events, and the monitoring of waiting times became mandatory with set performance targets. And our speakers will discuss each of these activities in detail in a while. But what this timeline shows us is that norms and standards have really formed a backbone of quality initiatives in the South African health system. But the question then is how have they shaped or influenced the delivery of healthcare services? And what is the frontline experience with their implementation? And more, how can they support quality improvement and meaningful change? Luckily enough for me, I don't have to answer any of those questions. We have three fantastic speakers to do that. And indeed, there are more people in the room who have experience, and we would like to hear from you. With that being said, I have the absolute honor of introducing our speakers for the day. First, we have Zelda Neethling, Zelda has actually served in the South African health system, working in primary healthcare for 29 years now, and she's looking forward to a well-deserved retirement. And we are happy that we could hear from you, Zelda, before you leave and go to your well-deserved break. And next we have Sibongile Dlaba. Sibongile is not only an experienced nursing manager, but she's also a keen scholar, and she was actually awarded the best oral presentation at the recent African Nursing Conference, which happened in July this year. And next, from the province of the rising sun, we have Mary Kekana. Mary is a health system leader. She was actually also recognized as the best primary healthcare manager in Mpumalanga in 22-23. And she also is a WHO PhD Pathfinder Fellow. Lastly, but certainly not least, we have Winnet Chinogwenya. And Winnet is an experienced QI specialist, and she has actually been involved in the design of large-scale QI programs that have been successfully scaled up nationally, influencing the development of quality healthcare systems across multiple provinces. So we have really a great line up for the day. But first, we will hear from Mary and the Emma Kazeni and Steve Chwete experience or story. Mary, over to you, and thank you.
Thank you very much, Mr. Motshweneng, and greetings to the seniors and also the colleagues on the platform. Yeah, I'll be taking you through the benefit and also just the burden or the challenges around compliance and also its influence on management, service delivery, and also the morale. Thank you. This is just my outline. If we can just go to this. Yeah, thank you. This is just my presentation outline, the layout, and just the background, facilities assessed, assessment bodies of the profile, and also the findings and also the experience of our managers or the teams on the ground. And also just to offer you the background to say, Steve Chwete and Emma Kazeni is based in Nkangala. It's one of the districts in Mpumalanga. You can see the arrows there. They are just adjacent to each other. They are two sub-districts. And also just to emphasize that Steve Chwete is just a proof of NHI CAP site with 15 facilities. And in terms of compliance, OHSC is 14/15 facilities. And then Ideal Clinic is 15/15 consistently so. And then one CHC was also evaluated by South African Nursing Council. And then AXA in most facilities came and supported us as well. And also the DPME, Department of Monitoring and Evaluation, visited 2 facilities. So we just want to feel, because the bodies come to our facilities and then we just want to get a feel of our teams on the ground to say, how do they feel and how do they perceive their visits? This is just a profile of our facilities. We have Middelburg Extension 8, which is loaded in terms of visits. You can see it has been visited by OHSC, Ideal Clinic as expected, AXA, which is the Auditor General, and also DPME. And the list is our facility, Waterfall Boven, with Office of Health Standard Compliance and also Ideal Clinic. So the rest of the facilities in between, they are just equally visited. In this table is just the assessment body, its interest and the area of influence, and also the key findings. I'll be only concentrating on the interest, and the common things here, the common themes around primary interest is the patient safety, is the quality of healthcare services, of course, professionalism and ethics. This is something that comes, frequently in terms of the interest. And then when you go to the influence, they've got common influence as well, which is mostly quality assurance. And the key findings in terms of Office of Health Standard Compliance documents, you'll find that in terms of the SOP, they will be looking at that area, and then you'll find that the SOP is addressing something else. Infrastructural issues, maintenance is a challenge as well. It was a finding. So, for example, maintaining your broken handles, your broken windows as well. It was a challenge, and also our old facilities that also raises a burden in terms of complying to these bodies. Of course, the certificates, the COCs, whereby for example, the electrical certificates also in all facilities, you'll find that there's still a challenge in getting those certificates because facilities have been built 30 years ago. Thus, we can't have, but for new clinics, we find that we do have. So those those findings also they apply to ideal clinic because they actually measure the same thing. And also the issue of trainings, your basic life support, BLS, ICSM, as well, and also adult primary care, which is also a challenge in terms of trainings. South African Nursing Council, the finding, it was the issue of the CPD, whereby CPD is a new concept in nursing, and we're expected, according to South African Nursing Council standards and norms, that we should be having a committee which is sitting, we should be having a database of all nurses that attending CPD accredited courses, how many, which are those nurses that are lacking, what are we doing about them? So it was a finding. And of course, in terms of the shift leader, because it's a 24-hour, the facility that was supported, they find that also the shift leaders, they don't have the same qualification as the operational manager, of which the recommendation was to say they should be having that. Auditor General of South Africa, in the facilities that they visited, there were issues of replenishment of items in the emergency trolley, of which the recommendation was to say immediately you are using an item, after that, you should replenish immediately. You don't have to wait even after 2 hours. And some poor recording as well was observed, whereby that Mukiti Kekana on my appointment card or HPRS, but when we go to the file, it's Kekana. So these are two different things. DPME findings, the Quality Learning Center concept, it was also a concerning issue to say we should be having the terms of reference, we should be having the sitting with the private sector, discussing issues of referral and improving health outcomes, and also quality issues. SOPs, not talking to the policy guideline as well, I've already talked about it. And also the issue of digitals, whereby some computers, desktop, they're not connected to the printer. OPM not having also the departmental emails, they are using the Gmail. So it was also a finding on that. And as I said, these are just the common findings. To say the top 5 common findings from these assessment bodies, it was mainly the infrastructural issues, documentation, as I've said already, the SOPs, the resources, and issues of procurement as well, because you find that you order this item, but when you get when you have the deliveries, it's something else. It's not what you've ordered. And also the HR, we can't talk the issues of service delivery, and we're not talking about the human resource. It's one of the 6 building blocks as well. And of course, trainings, as I've already talked about it. And of course, our quality improvement plan to say everyone comes to the facility, or every assessment body comes to the facility. When they leave us with action plan, their findings, and of which we are expected to do the action plan or the QIP. And with the saying is to say it should be inclusive, it should be collaborative, so that it enhance integration and avoid confusion, because we're just pushing for better health outcomes, whatever the program or the assessor comes to the facility. Thank you. This is just the experience of operational managers to say, how do you usually prepare? It was a question to say, how do you usually prepare for this assessment? And the response was to say they delegate team leaders as per assessment tool or the area, and then they do the check-in meetings to say, okay, on Monday, Mary, you are the team leader for the emergency room. Wednesday, they meet with the operational manager and then they do check-in meetings to say how far. And of course, the preparation also, they are being assisted by the area managers and also the PhD supervision tool, which is linked to the assessment requirement. And the benefits of assessment, mostly managers, they said it's improved quality, definitely. And they are happy because they touch base with the theoretical part, which is our SOPs, our policy guideline. And due to the objectivity of the assessments, they said they are happy because it's an eye opener as well, because things now they are seen from a different eye. And just the challenges, they cited the challenges to say team becomes anxious as they come, and also the assessors come, and also they got support from the sub-district, from their supervisors, to the district to a certain, to a limited extent as well, and the province and national as well. Remember, the ideal clinic, it clearly stipulates to say whose responsibility is this one in terms of that, on that area. So those are just the feelings that they got. And of course, the issues of NNVs is a challenge. Simple face masks from the depot is not there. You find that they don't have, and this really affect the compliance because it's one of the item in the emergency area. Thank you. In terms of the support, as I've said, they said they are really happy with the support. If we can just go back, Mr. Motshweneng, just to finish that. And we come now just to the recommendations. To say in terms of the recommendations, they would like to be supported more with the resources. As we recently had the issue of malicious compliance, we are trying just to avoid that. It's not happening in our district or sub-district, but we are worried of that. And also we are saying we are ready now to receive the spot checks or unannounced visits from the OHSC, yeah, and also other assessors as well, AXA or your DPME. And assessments also should be everyone's business. And also assessors, they should be calibrated so that they talk the same thing, because definitely you find that this assessor accept this document or another measure, but then the other one will say, no, it's not happening. So the calibration of the assessors is what they felt, the OPM, that it should be done. And we should be sustaining, as I've said, and we should be defined actually by the community. It should be patient-centered, to say our communities should be the one who says, this is our clinic, this is our clinics, and yes, this is an ideal clinic. Remember the operation Pakistan, it was very clear to say patients should be the one that defining that. And also we are saying also our employees as well should be very comfortable and happy about the service they provide. And you know, the PEC will be telling us from the community patient experience of care, and also the staff satisfaction survey also should be talking to each other to say everyone is happy, and then we'll be having a happy product on the center. This is just you know, the moments to say, as much as there are challenges and it's mandatory that we comply, but we are happy in terms of the new facilities. You can see we have our streams in terms of the ICSM. One of them is the chronic care, very clean, neat. You have our, on the just on the middle picture, we have our nurses there, clean, nicely, professionally appearing. You can see it's a workspace that you can really look into when you are sick. It's written even the help desk. And just on the extreme right, we've got our very beautiful building with solar geyser there and the ambulance as well. And we are saying with the OHSC, ICRM, you know, AXA framework, we can be able to be awarded and recognized during the MEC, during the provincial awards, because these are really credible software that you can get data to say they're performing. And we are saying also, as much as we are okay and we are happy about our compliance, we should also be you know, having good health outcomes in terms of indicators, and so that we really say our population is very healthy. So our indicators, your TB success rate, you know, our NCD indicators as well, they should be talking, saying also we confirm that the facility complies in terms of all the assessment bodies. Thank you on that note, and ke a leboga, inkomo, sithokoze. Thank you very much.
Inkomo sithokoze. Thank you very much, Kekana. With that, colleagues, we're gonna forge straight ahead, and next we are going to hear from Sibongile. Sibongile, over to you.
Oh, thank you very much, Mr. Motshweneng. I'll go straight ahead. Good afternoon, colleagues. Good afternoon, everyone. Today I'll be presenting on frontline experiences with the implementation of the patient safety incident reporting and learning guidelines within healthcare facilities. This presentation draws from the real experiences and observations from frontline healthcare workers, focusing on successes, challenges, and recommendations for improving patient safety culture and reporting practices. We can go to the background slide. To give a background, the Global Patient Safety Action Plan 2030 by WHO aims to achieve zero harm in healthcare. In South Africa, the National Patient Safety Incident Reporting and Learning Guidelines was introduced in 2017 and revised in 2022 to create a uniform national framework for reporting. The goal is to standardize how we report, investigate, and learn from incidents, and this aligns with the Office of the Health Standards Compliance, Norms and Ideal Health Facility Framework, both of which emphasize patient-centered, safe, and continuing improving of healthcare systems. Common PSIs. Most facilities experience these top 6 common PSIs. Amongst them are abscondments, patient falls, maternal deaths, early neonatal deaths, pressure injuries, and medication errors. We can move to the next slide. Despite the challenges, we found that in practice, most looking at the medical legal data, we can see that there is a financial impact on the patient safety incidents. Between 2015 and 2021, Gauteng recorded over 2,400 medical legal claims valued at more than 24 billion, with over 1 billion already paid out. Similarly, in the Northwest Province, there were 230 medical legal claims worth over 1.5 billion. These figures show that not only the human cost to harm, but there's also a financial burden on the health system itself, which then highlights the importance of strong patient safety incident reporting and learning systems. We can move to the next slide. Despite the challenges, there have been some positive outcomes. My research team and I conducted a study in the Northwest Province, to be specific, in the Dr. Kenneth Kaunda district between 2023 and we completed in 2024. The study was around the implementation of patient safety incident and reporting guidelines, and it was a qualitative study, which 3 hospitals participated with 123 participants. Part of our findings showed that frontline health workers show that there's a growing awareness on the PSI reporting since their introduction. There's reduced interdepartmental variations in the reporting, which allows easier tracking and follow-up of reported incidents. There has been seen that there's increased vigilance, and which has improved clinical practice. This has promoted more responsible behavior and accountability amongst healthcare professionals. The PSI guidelines are viewed by the participants as a means of protection for the healthcare providers. And the reports, they say they provide an objective record of events that can be used in case there's a litigation against the state. And also this has improved the monitoring of error trends. Then we move on to the challenges. The study has found that the challenges that remain widespread and deeply rooted were limited knowledge on the national guidelines. There's still shortages of trained staff, and staff reported that they don't have time to report effectively. There's a high exclusion of junior staff categories from the incident reporting, especially on the nursing personnel which is the enrolled nurse and the nursing assistant. Also, they experience that there's a punitive culture that discourages open reporting and learning, especially their managers, making them write written warnings. There's weak data usage. Reports are often collected, but not analyzed for trends and systemic learning. We also found that there's limited leadership engagement and inadequate follow-up on reported incidents, which then leads to ineffective investigations into the reported incidents. The recommendations that came up to strengthen patient safety culture and improve implementation of the reporting, PSI reporting itself. The participants recommended that ongoing training would help in terms of developing programs for healthcare professionals to improve understanding of the guideline, the SOPs, and all related legislation, ensuring adequate staffing and infrastructure to support the demands of quality delivery, patient care delivery, and also integration of patient safety incident reporting into the curriculum, especially of the undergraduate programs. Also to foster an organizational culture that encourages open reporting of incidents without fear of reprisal, supported by clear policies and leadership commitment. What would also assist is regular assessments and audits to monitor compliance with effective PSI reporting and learning systems, with feedbacks mechanism to drive continuous improvement. We can move to my last slide. Thank you very much for your attention. I leave you with this quote: safety is a small investment, but for a rich future. Those are my contact details for further engagement. I thank you.
Thank you so much, Sibongile. Quite succinctly put, and I think important experience drawing both from research and tacit knowledge, practical experience. We appreciate it. And colleagues, please feel free. We encourage you to engage us and engage the speakers, ask questions, share thoughts. Using the chat function. We started at the district system level and we went to the hospital. Now we are going to the clinic level, primary healthcare facility level. And I would like to invite Zelda to share experience next. Zelda, over to you.
Good afternoon, colleagues. I'm Zelda Neethling, presently the operational manager for Kenton-on-Sea Clinic in the Eastern Cape, and thank you for having me. I was asked to give you a brief background and overview of how we implemented the booking system at our facility, which is working very well at the moment. The ideal clinic concept was introduced nationally in 2015, and then our clinic underwent its first assessment in 2016.
Sorry, Zelda, I don't think your camera is on. Can you switch on your camera? We can't see you.
We don't have a camera that we can see here. We tried, but we couldn't find it.
Okay, no, that's fine. You can proceed. Thanks.
Okay. Our clinic underwent its first assessment in 2016, and that marked the beginning of our continuous improvement journey. Part of our ideal clinic requirements is to conduct patient waiting time surveys, and during the survey in 2017, we in the data that we received there was indicating to us that patients waited too long. Then by the end of 2017, we recognized that it's now really becoming urgent to implement a structured booking system, because we were working on a first come, first serve basis, resulting in patients arriving as early as 5 o'clock in the morning at the facility just to secure a place in line. And patients on farms already started walking at 3 o'clock in the morning to be sure that they can attend the clinic in time to be helped. To introduce a booking system to staff is a change, So you really need to get your staff on board and not just dump everything on them. So a staff meeting was held with all the staff, from the community care health workers up to everybody, to get buy-in and suggestions for the new system. The concept of the appointment system was explained to all staff members, explaining to them why the booking system must be implemented, how are we going to implement it. And we conducted the proposed exercise with staff after waiting times were analysed first. That exercise proved to be one of the most important tools in starting appointment systems in the streams. We initially started with NCD because that was the main blockage at the clinic. Can go to the next one. During our staff meeting, we brainstormed and we initially decided on a 2-hour appointment slot. And this collective included all staff at the clinic, as I said, professional nurses, community care workers, the data capturer, post-basic pharmacists, and other supporting staff. We also included the ward counsellor to inform him about the clinic's plan to implement the appointment system and explain the rationale behind it. Since the clinic doesn't have a clinic committee, this step was crucial for our community engagement. Then we did not just jump in and implemented the booking system. For 4 months, health education sessions were conducted in the waiting room during the mornings and also in the afternoons. The patients were informed daily about the new system and its benefits and given opportunities to ask questions. We explained to them exactly how the appointment system will work, why there is going to be an appointment system and what the benefits to them will be. And they were given the opportunity to ask questions and voice their concerns. And we decided also that we will give them a specific time when the booking system will be implemented, so that everybody was on board as to when this is going to start. So the patients were prepared and informed, and it was to ensure a smoother transition to the new appointment system. Implementing the booking system, in the first week, we realized already that the initial 2-hour time slots that we decided on in our staff meeting is not going to work. It was total chaos. The patients, some of them arrived at 9. Everybody arrived at 9. Or everybody will arrive at 11 o'clock if the time slot was 9 to 11 without proper scheduling. And the patients couldn't get the concept if the time slot is between 9 and 11. They don't have to be here 5 o'clock in the morning. So there was no improvement in the waiting time at all. So it was back to the whiteboard, and we had another session where we brainstormed again and tried to overcome this problem. And then we came up with a decision to give the patients specific date and a specific time, which will also give them the opportunity to choose their preferred slots that suits them time-wise. We also decided against one central booking system because not every one needed the same time. If I can just mention an example here, if you see a chronic patient that is just coming to collect medicine in 15 minutes, that will be enough. But if you must also do bloods, your work become more and it will not be enough time, only 15 minutes. So we had to work out our times that the patients will be seen also. And then we decided that we are going to give each consultation room its own appointment book for better organization. So if you're in room 1, the PN in room 1 will give you your appointment when you are being consulted. Through trial and error, we continuously made adjustments to optimize the process. In the beginning, there were some patients that did not have enough time. We had to adjust that time. Then patients did not turn up for their appointments, and we had to adjust that, address that. So implementing this booking system needed a lot of commitment. And the result of being committed to our booking system was that we almost have a permanent, perfect booking system. And you will never have a 100% foolproof booking system. There will always be a problem. And just to give you an indication as to the effect of the booking system and why it's not going to be perfect overnight, in 2018, when we do our initial waiting times, it was 3 hours, 20 minutes. Then after struggling, adjusting, implementing the new booking system, we came slowly down to 2 hours. Then COVID happened in 2020 when we were on 1 hour, and we did not really implement the booking system in COVID time because we only saw very sick people and emergencies during that time. And 2023, we started off with an hour average waiting time. And now in 2025, we are on 8 minutes, which is our average waiting time in our clinic at the moment. Can go to the next slide. The golden rule for maintaining the appointment system is sustaining an effective appointment system really requires continuous evaluation, staff coordination, as well as patient engagement. The following principles from the foundation of a resilient and patient-centered approach. The golden rule is regularly monitor, not only by your waiting times, also by listening to your patients. A school child cannot be, a chronic school child cannot be booked 10 o'clock in the morning. They can choose in the afternoon when the schools are closing to have an appointment in the afternoon, as can any other patient choose a time that is suitable for them. And if you have it available, you can give it to that patient. Patient waiting times consistently to identify service bottlenecks and periods of inefficiency within the daily schedule. Also, do not give waiting times to the same people over and over again. Do not always give waiting times to chronic people, because you also need to know how long are your acute people waiting, how long are your mother and child waiting, how long is your fast lane people waiting for service. Then adapt according to your problems. there are things to be considered regarding staff assignments. If somebody is on leave, there's a gap. You need somebody to fill in. You need to adapt your booking system in the consultation room according to when your doctor will be visiting, when you will have dental services that in with us are taking place in the consultation rooms. You also need to educate your patients. Unfortunately, you will have to stand there almost 3 to 4 times a week, even if you have a well-flowing booking system. And again, tell them the importance of honoring their appointments and notify them promptly when services are disrupted due to staff unavailability, due to an emergency, due to anything that can disrupt your booking system or your time management for that day. That is also what I tell the staff when I train them in booking systems with the ICRM trainings that I also participate in, that they give up too quickly. This is unfortunately an ongoing thing, and you need to revisit it at least once a week to see that your system is flowing. Thank you very much.
Wow, wow. Thank you so much, Zelda. Really great work that you and the team are doing with some really tangible impacts. And I think, colleagues, we have had from 3 different initiatives, and all of which are linked to norms and standards. And I think, borrowing from the words of Mary, it's a story of 2 tales. There's both benefits and burden. But I think what is key that I'm picking up across these 3 presentations is that strengthening facility level capacity is important, and not only in terms of resources, but also strengthening the leadership capabilities that are needed to make sense of multiple demands and needed to collaborate with others. And also, this is crucial for nurturing the enabling culture where people can actually fail safely and they can openly report and communicate errors and they can learn together. But as mentioned earlier on, these were 3 sets of formal inputs, but there are other people in the audience, and I think we know you have great experiences. So we're going to open up now for some wider engagement across the room. And for that, I'm going to invite Bernard. Bernard is the professor and head of family medicine division at the University of KwaZulu-Natal. Over to you, Bernard.
Thank you very much, Oupa, and thank you very, very much for those wonderful presentations. I think there are already quite a few questions in the chat around that, and it's really, I mean, they like in very different ways kind of touch on a whole diverse range of issues. So Lucy first requested that maybe could each of you from the 3 presenters what is, so can you clarify the one key lesson that you want to share with others in how to support implementation of existing norms and standards? So what is the one thing that you think is absolutely key? Maybe to start with Mary, please.
Thank you very much, Prof, and greetings to your good self. Just one key lesson that a manager or a team member should just take or just know is that assessment, it should be a daily activity in the facilities through self audits, maintaining that standard throughout the day, work smart every day. So that should the unannounced visit come, you are still safe. Anyway, we're doing this for patients, not for paper and just for popularity, but this is for patients. That's why patients should be defining us. And lastly, is just to say part of that is that it should be everybody's business, starting with the security official there. When she or he register patients there for safety issues, he should be having a name tag professionally looking, good attitude, until to the OPM of the facility or the area manager of the facility. So it should be everybody's business. Everyone should be knowing his or her role in terms of these assessments bodies, or in terms of compliance. Thank you.
Thanks. That's so. I think the idea of how do you make it part of your everyday life really comes out in that. Sibongile, what would you say is the key thing that stands out?
Thank you so much. I think the one thing that stands out, amongst other things, is learning from, I think, incident reporting. Yes, people have, I think, now gotten used to the reporting system itself, but we are lagging behind on learning from the incidents so that we prevent recurrence. I think role modeling by leaders would also assist to lead from the front and show the staff and practically show them how to, for example, just to fill the Annexure A of the reporting guideline form would actually assist a junior, somebody to feel included in the reporting system. And also the assessments that we usually do, the ones we call the audits, they should be learner driven. So what then we do 50 assessments if we learn nothing from them. Thank you so much.
Great, excellent. So the whole idea of a learning organization, it's great to audit and look at the things, but how do we learn from that? The key lesson. Zelda, what stands out for you?
I don't only have one thing, I have three things. Unfortunately, there are so many questions flying at me here on the screen. But first of all, and the most important, is teamwork. And with the teamwork, get your staff on board. Do not do this on your own. Communication to your staff and to your patients is very, very important. And then be consistent and maintain your consistency. Don't have a rule that is working for today, but it's not working for tomorrow. So consistency is really that's very, very important.
Yeah, thanks. I saw in one of your slides, you had the key insight at the bottom, and that's nearly what you said now. And what for me really stood out from your presentation is the kind of how useful chaos is. Like that the chaos is not failure, but that is really incredibly helpful information that what you tried didn't work. So you don't need to try that again or carry on with that, but you can imagine something else. That's really brilliant. Let me just go to another one question that was from Amanda about the PSIs and the classification of abscondments. Sibongile, do you want to comment on that? Some of the clients are basically refusing hospital care rather than absconding. So like when is it the one and when is it the other?
Thank you so much. Abscondment is quite common because of its ethical and legal implications on the facilities that provide healthcare. I think that's why it's ultimately then classified as severity code 1, because somebody could say, okay, the patient left. When they came, they were priority 3, then what? But then if you haven't assessed them or completed your service with them, the outcome, they can possibly get injured, possibly collapse at home, possibly die, and then the family, they can then come back and litigate the state. So it is the catastrophic outcome that then makes the classification of a higher classification, making the abscondment very high classification. So the organizations become very much at risk, and that shows in how we're losing the health funds into now the medical legal claims. Thanks.
Yeah, thanks. Melinda Potrita also asked how I think that goes to Zelda, how were you able to communicate the new system to the community? So, because quite often the system exists at a community, but you only find out when you go there. And so, like I went to the Master of the High Court the other day, and there's a sign next to the window saying we only accept documents on Thursdays. But if you're outside of that building, how would you know that this only happens on Thursdays? So how did you go about that?
As I said in the presentation, our first step was to approach the ward councillor. And the ward councillor here with us have his own people, health people in the leaders in the community that started spreading the word. And then we stood in our waiting room for 4 months before we even implemented the booking system. So for 4 months, we communicated to the patients the booking system, what we're going to do, what the rules are going to be, what we are going to try. And only after that did we implement or started implementing the booking system, because in 1 month you cannot get to everybody. So we decided we will do it over a period of 4 months. So that is how we communicated to our patients.
Yeah. Okay, and then kind of the other question that also was for you from Cheryl was, how did you address the patient non-compliance? So when people don't come or come for a different time slot, but they didn't come at the right time, how did you go about managing that?
I'm very happy about that question, because that is usually one of the first questions that I ask staff when I do the training is, why did your booking system not work? And then they will tell me, because the patients are not turning up on their time. My answer then always, or my question then always is, what makes you think they will turn up in time, or they will adhere to their appointment? Because that is a perfect booking system. You will never get that. So what we do is, when we have patients not turning up, we have slots in the afternoon where we do the late people, but late people also need to be disciplined. So we will allow only 5 slots in the afternoon. For the rest, the medicine will be prepacked and it will be delivered by the health workers, but it's not going to become a habit, because at some time the patient must take responsibility for their health. So we accommodate them by them. Some days there will be 3 or 4 people not turning up for their appointments. Some days there will be 15 people not turning up for their appointments. Stand in the waiting room, addressed late coming and not adhering to the booking system. That's no reason to give up on the booking system.
I think it's kind of within all of the systems, like one of the questions for me is around kind of how person-centered are they? So if somebody is dependent on a taxi, and it's really difficult to be kind of to plan to be there 10 minutes early or 15 minutes early, like if the taxi is not full, it doesn't go, especially from farm areas, like then a booking system may be difficult to adhere to. So was there flexibility for people that kind of where it is difficult to be on time?
Yes. That is why there are diaries in the consultation rooms and not one diary for everybody. So if it is a farm worker that needs to drive, say, 10 or 20 kilometers to get here, we will ask them what time will be okay for you to be here on time. And then the patient will tell you, sister, please, I need 12 o'clock or 1 o'clock. And we try to accommodate that as far as we can. And we are very long, for a very long time that we're busy here. So most of our glitches are sorted out at the moment. The patients also know that if something happens and they cannot adhere to their appointment, then they can call us. And we will prepare their medicine and somebody will come and then just pick it up for them.
Yeah, excellent. And has it impacted on the head counts in any way?
Not really, because the chronic patients are being helped a lot faster. So sometimes we have extra PN that are doing just the acute people. Staffing is a problem. If you don't have that extra person, then your acute people must be slotted in between your chronic people. But if you have a stable patient that is not yet on CCMDD, you can see them faster than 15 minutes. And my staff utilize every moment that there is. So they will slot in then an acute patient in between before they see the next person. So the flow is very fast. So I have 3 PNs and we see close to 1,800 to 2,000 patients a month.
So you've just answered Jenny's question. How many PNs do you have? There's a question from Krishna I think this is probably aimed at Sibongile. How do you improve the level of reporting PSIs? The very low currently undermines the ability to understand and assess root cause of patient harm. And I think that is quite often has been also criticisms where, for instance, if a referring hospital refuses a referral, that often doesn't get noted as a PSI. So even if the patient needs ICU referral, and the doctors they kind of give you the runaround and saying, no, you first need to do a UNE and kind of until the patient dies. When does that become a PSI? So how do you address the level of reporting? Sibongile?
I'm here. Am I audible?
Yeah. Yes.
Oh, just a bit of network challenges. Can I go ahead?
Yes, go for it.
All right. What I've seen in facilities where they reported that they have low reporting rates of PSIs.
Yeah.
Is that you might find that the reporting culture is not so positive.
Yeah.
Yeah, they have to look at the reporting culture itself. How are the employees perceiving the reporting system? Do they see it as punishment? Is the just culture implemented? Do we address the incident and not the individual? Because once you start attaching the incidents to the healthcare practitioners, then people are less likely to be honest and to do self-reflective practice. So in summary,
so this is, I think Sibongile, you touch on something so important, is the kind of organizational culture in which one can improve quality. So kind of that, and that actually is a really complex issue to manage. How do you ensure that it kind of comes to the learning organization again? How do we make sure that we're actually able to learn from the chaos, from when things don't go right, when we try things out? Okay, great. Thank you very much for those questions. And we have got one more presentation. And I think this is actually going to be a really nice transition to the next presentation. That's from Winnet. She's been introduced already, and she's going to talk about beyond compliance. How can norms and standards support quality improvement? Over to you, Winnet.
Thanks, Bernard, and good afternoon to all the guests on the webinar. I'm just going to share my screen. Just let me know if you can see it.
Yes, we can see it.
Perfect. Awesome. Thank you. So thank you to the Salad team for giving me space and a voice to be able to input on such an important topic of quality in healthcare. It's also an area that's very close to my heart that I've dedicated over 15 years of my professional life supporting the district health system. And I've had the privilege to work as well at facility, at provinces, and currently I am serving at the National Department of Health. So I am under the Genesis Analytics consulting firm, and I'm seconded into the National TB program, where I am supporting a lot of change management activities and initiatives that the TB program has embarked on. So this is a very exciting topic of discussion. And I just want to thank my previous co-speakers who were able to lay a great foundation, I think, for me to actually chime into this important topic. I won't say much about this, but I think what I just want to reiterate is how exciting a time it has been to see, the commitment from a global scale and even at national level, where we are seeing a true commitment towards health system strengthening. And what's nice about that is that the health system strengthening, they are really acknowledging the important role of quality in driving, to create stronger systems to be able to achieve that universal health coverage that we are all aspiring to. So we see it being translated, from the WHO 6 building blocks. We see it being translated further in our context through the national core standards, the Office of the Health Standard, and the Ideal Clinic, which my previous speakers have detailed, the way that they are working in there. So it's an exciting time for quality practitioners like myself. So I think speaking from the experience that I've had, I think over the years, one thing that sticks out is that, there is a certain feeling that comes when people hear the word quality. Most times when we are starting to do support work in quality, most of us veer towards the orange block of my slide. People think of inspections, people think of scores and reports, they think of investigations and reports and accountability. All of these are a bit of a triggering word for most of us. But I'm hoping that as the conversation matures through this discussion, I'm hoping that, we actually start to also see that there are benefits in the inspection scores and investigation. The ultimate reality is that you are able to see that quality also saves lives, also helps us to accelerate effectiveness, efficiency, and equity. And it also makes systems reliable. And believe it or not, it also helps you to, as a healthcare workers, to actually enjoy work, which is something people don't believe, I think, when we start talking about quality. So maybe let me just root myself before I go further. I always love to first define what quality means in this context. And I find it useful that, I don't need to define it as per what the text say or what we have read, but I like to define quality from the lack of it. I think once we emphasize the lack of it, people begin to see the role of what quality is. So we see it, and I think my previous speaker spoke about, there's things like avoidable mortality. If quality is not in place, we will see avoidable mortalities occurring. We'll see patient sufferings unnecessarily. We even see disabilities, errors, and complications and wasted resources. So once we understand that, we have to realize that the system is actually built for us to serve the patient. Everything that has been spoken about around quality and about creating strong health systems, we want to make sure that we remember that quality is about putting the patient at the center. But, we kind of end up in a situation where we're saying, how do we do that? How do we inspect people and ask for reports and make people accountable, but at the same time, make things effective, make things reliable, and make things exciting at work. It kind of feels like a double sword situation. But I would like to introduce you to something that I think was a paradigm shift for myself, where I came across the total quality management, which was a model that was obviously created beyond our borders by Duran. And it's popularly known as the trilogy. And what it emphasizing is something that brings us some balance between these two paradigms of quality as something that's punitive and quality as something that brings joy. And the balance comes in three folds. The first thing is that there is perspectives to quality. The first one is quality planning. So quality planning is all about making sure that quality is built into our services right from the beginning. And we see this happening, I think, in most of the efforts we've seen with our national health system. We've got excellent SOPs. We've got excellent clinical guidelines. This is essentially showing us that quality can be planned through at the beginning. Similar to when you buy a car, you know, it actually comes with a manual. But as we know, having the manual and having the car doesn't mean that you can drive, right? So you will need to then experience it. And this is where quality control comes in. Quality control comes in to then check and monitor and inspect, not to be punitive, but to actually check if the goals, the quality that we planned is actually serving the purpose that it was designed for. So quality control comes in to support the quality planning that has come in. So another example is when you now have the car, you need to take the car into services, right? You need to, it has a timestamp where you go to service it to make sure that it's still in its good condition and improve some of the gaps that you would have experienced, similar to our health system. Once we have picked up some of the issues and some of the gaps, we then shift our focus into quality improvement. So quality improvement then comes in to actually do continuous, deliberate, structured work to deal with the problems and the gaps that we would have seen in the quality control process. So what I'm trying to say here is that all of this work in an integrated way. There is no one that is superior than the other. What you see is that each of these blocks, these perspectives of quality, lean upon each other. And I'm hoping that this gives you fresh light into what quality management actually looks like. So when you hear reports, when you hear inspection, it is coming in from a space of quality control so that we can improve it. And once we improve it, we factor that in the way quality has been planned. So some of the lessons that I can share, I've got only 3 lessons I can share here, but I can go on and on. But the key things I want to leave with you is that, you know, for quality improvement, right, to start becoming a critical component within our culture of the way we do work, we need to be able to admit that we have to create the right foundations to catalyze a culture of improvement. So a culture of improvement, it really is about making sure that there's support structures that will enable facility level people to be able to do quality improvement. Majority of the challenges we've seen at district health system is that facilities try their hardest to do quality improvement. I think my previous speaker shows the effort of how they actually changed their system of waiting times. But facilities similar, I've heard similar stories where they try so hard, but when the foundations are not put in place, which starts really at management level and filters through, we need to be able to actually create a culture of improvement, to create a fertile land for things to actually stick. We also, I think we have spoken a little bit about how capacity building is important. Quality improvement is actually a science in itself. It's a structured process. But I think we see ourselves finding ourselves developing and taking on quality improvement approaches, which the implementers at the district health services cannot connect with. So we need to be in a position where we take time to take that scientific approaches we have in quality improvement, engage with the implementers at Frontline so that they can own and that they make it something that is relevant for them. And thirdly, which is in the same vein, we want to make sure that a quality improvement is accessible. Accessible, meaning that it needs to be understood as a simple way of working. We need user-friendly tools and process models that doesn't center on unnecessary jargon that sometimes quality improvement brings in its approaches. So what I'm saying is that these 3 points are the major barriers we've seen for people to create a culture of improvement. Oops. So I've spoken a mouthful, I think, in terms of things that I've seen, things that I've thought about over the years. But what I want to do now is to give you a true example of a fresh work that we've done with the district health system in Gauteng, where we've been supporting the Sedibeng district in improving loss to follow-up outcomes within the TB program. So this was an approach that obviously is pinned under quality improvement principles and theories. But what we did is that we laid it out to the district health system to start to inform and co-create with them this model, which I have packaged now as the total quality approach, which speaks directly to the problems within the TB program and which speaks relevantly to the issues of loss to follow up. This is a 3-layered total quality approach. The first layer, and I'm starting from my left, which might be your right, I'm not sure. But if you look at the bottom where it says foundations, it emphasizes that we made deliberate efforts to actually take time to create the right foundations, to create a fertile environment for quality improvement to actually thrive. We talk about things like shared understanding and purpose. This looks like having several meetings and several disagreements, but coming to a place where we compromise with different stakeholders to have a shared goal. In this case, loss to follow up was the priority that people landed up on. We had difficult conversations, right? Change comes with difficult conversation. We need to let go of some things that we are attached to. We need to let go of some habits. So there were some things that were not going well within the district that we needed to have to actually talk honestly with and then move forward. What was inspiring was after all of that, we actually created a culture of collective dialogue and learning. So what we did is that we established a technical, like a change working group, which was termed the technical working group, in which now we come in with our shared purpose, putting aside all our difficult conversations on the side and begin to start having dialogues about improvement and what we are learning. And through that, people started to feel differently about what accountability means. Accountability is not about being punished. Accountability is not about being shamed and blamed, but it is about learning and sharing and saying that this is a mistake, this is not working. And then obviously we needed to make sure that there were measures put in place to remove the barriers that people were actually talking about. Once the foundation was put in place, we were now ready to begin to start talking quality improvement. So what we did is that we needed to make sure that the change agents who are going to be the drivers and the keepers of the interventions were familiar with some of the principles and the concepts of quality improvement. So we set out to do 4 very important quality improvement workshops that focused on key lanes of the improvement process. We needed to make sure that we understand our systems. So that entailed doing a lot of root cause analysis work. And that included, teaching people things like fish bones, teaching them about 5 whys, all of these exciting tools that they were able to actually connect with. We talked about data for improvement. Quality improvement is a data-driven process. We talked about how do we enable conditions for change. And then obviously we need to talk about once we have seen the change that we want, how do we spread that and scale it so that it is sustainable. Once we were in a very good place where the change agents were confident, we were now ready to go and do quality improvement at the facility level. So what we did is that we pinned ourselves, I think, from the popular plan, do, study cycle. But instead of calling it the plan, do, study cycle, we asked the implementers to say, how can we make it easier and simple for you? So we then co-created something that they could easily follow, which guided their improvement meetings and their conversations. And as you can see, it has got some timestamps. I'll move on to this so you can see it a bit more clearly. So you can see it's not talking about any hard concepts. It is talking about the things that they know about. Once using a data-driven approach, they were able to identify quickly the errors, the omissions, the gaps that they had, and we call that removing stumbling blocks. Once that is out of the way, we can then start to review and think about how we are doing our work differently. From there, through the discussions, we obviously picked up some challenges. On step number 3, we taught them how to rank and to prioritize. So this is where the problem solving starts. There's different types of problems that we see in our adaptive process. We see complicated problems, we see complex problems, and we see simple problems. We capacitated them on how do they actually see these and how do they actually get these moving. And then the last one in purple is that we obviously drafted improvement plans to move it forward. And the red is basically saying doing it. And once we've done it, we do the cycle again. So we did this in improvement meetings at facility levels with the multidisciplinary team focusing on TB, focusing on loss to follow up. And this is how we built, how we moved from just a compliance process to actually activating improvement into action. So as I said, I think I can talk a lot about this, but I think I'll stop here and just highlight maybe the key things that I would like us to table in conversations. I personally feel that if we are going to achieve universal health coverage, we do need to continue talking about quality and making it a feasible reality in our facilities. We need to make sure that we design for the patient. A lot of our interventions are designed predominantly for the provider. How do we make sure that things are easier for the patients? We want to make sure that we talk more about culture over compliance. And culture is a daily commitment that drives improvement. Audit is just an event that tells us what is wrong. But from there on, there needs to be daily things that needs to be done. And I think, in most of the concepts I've spoken about in all programs, I think there is space for us to adopt a total quality approach. And then lastly, we believe in co-designing things, not coming in and telling people what they did wrong, but turning those scores and those inspections into meaningful things that will help them to actually design things that are relevant for their context. With that said, I think I'll stop here and thank you so much for this opportunity.
Bernard, you're on the
Sorry,
red.
I was struggling to unmute myself. So thank you very much for that input, Winnet. And I think it really pulls together very, very nicely kind of many of the aspects from the previous presentations. The one aspect that I know that quite a lot of people have struggled with, and that is the top-down versus the bottom-up. It's quite easy to say we're not doing it for compliance, but we're doing it for joy. But I mean, just to give a practical example, one of the quality improvement cycles in a hospital designed a new admission sheet that was completely aligned with an audit process, like clinical audit process. So it actually really kind of made sure that the admissions would be covered adequately. But then the medical manager decided, no, you can't use this because this is not DOH stationary. And so that joy of bottom-up creative problem solving and the top-down, no, we have to do it this way. Can you talk about that tension maybe?
Thanks, Bernard. And that's an excellent question and a real reality. And thanks for giving me that example. I think this is something that we faced, and I think we cannot be naive that I think our health system is organized in a hierarchical manner. There are protocols, there are specific things that needs to be adhered to. The tension is there. People talk a lot about the push models where we push things down to people. But then there's also what we call the pull model, where we make things attractive and then people want to actually participate. I think in relation to your question, one of the things that we have seen that happens, it is critical that as part of the foundation, it really is about engaging, respecting the system as it is. So it's critical, and we need to put our feet on the ground. the first point of call is to engage those managers, the people who have got influence and the people who are decision makers. Once they understand the benefits of this approach of quality, I think, we've seen that once they buy in, things actually move quickly and we begin to reap a lot of, results from that. So I think you are bringing in a very important issue in light there to say, let's not naively just say quality improvement, we're going to get there and change the world. We certainly need to ground ourselves in reality and respect the protocols that are there. But it is about, crafting those conversations to actually have a pull model. So for example, a stakeholder of a a hospital manager, you need to be able to talk about how quality improvement is going to help them to reduce waste and cost, maybe, so that they can allocate that resource into something else that has been troubling them. So there needs to be some deliberate, intentional work to be done with the top management for them to buy in. I hope I've answered your question.
Yes, thank you very much. And I see Jeanette has also responded to that, saying the stationery was designed through consultation. But again, even if it's designed and that is what we need to adhere to, how do you change something then? Like, how do you improve the local system if you can only adhere to rules? And I think that's kind of always the tension. Like, I think that is kind of something that one needs to work to. We are running out of time very rapidly, and I wanted to give Helen a kind of opportunity to kind of pull things together and to wrap things up as well. Helen, can I hand over to you?
Yeah, sure. So thank you very much. And I noted that at the height of the webinar, there were 125 people. So clearly this is a topic of huge interest and people want to talk about it. And lots of points have been made and reiterated, but just to highlight what I picked up is a few. So Oupa made the point that norms and standards are gazetted, so they are part of the reality and engaging them is not optional. Mary Mokete provocatively titled her presentation Benefits and Burdens, which was very helpful. And those tables were in themselves told an incredible message of the burdens of these accountability overloads. So I'm left with a question mark actually on that presentation of how can we rationalize, synergize, and align these assessment processes to reduce the burdens and maximize the benefits. Sibongile Dlabla's presentation highlighted the very big challenge of medico-legal claims and the huge imperative to address quality simply to deal with that massive challenge of liabilities linked to medico-legal claims. But, but she also provided a very honest reflection on this PSI and whether it really can be implemented in the context of a punitive culture, weak data use, and ineffective investigations. And my question is, will adding another assessment tool address those problems? And do we not have enough mortality and other audit systems that can address these issues? And is that the right response to the problem of poor patient safety? Zelda Neethling, I think in her retirement, could hire herself out to run masterclasses on how to run a primary healthcare facility. Clearly very, very inspiring. And what I took away from that presentation was this resilience, this persistence, this ongoing commitment, which was really exemplary. And I suppose the question I have there is how do we build that frontline leadership that is able to take that forward? And then Winnet, what I retain from that is the Durand trilogy, and the need to connect measurement with improvement, even though we think they have slightly different cultures and starting points, they actually should be seen together with a planning mindset. And so, my question there is what does it take to connect everything? So I will leave you with those final thoughts and takeaway messages and hand back to you, the organizers, Oupa.
Thanks so much, Helen. And many thanks to you, Bernard, as well, and Winnet. And I think there's a lot that has come up through these conversations, and I think we need to continue with these conversations in other ways. But with that being said, colleagues, we have come to the conclusion of our webinar, and just to really thank our fantastic speakers for sharing with us your experience and your wisdom, and really thank our facilitators, Bernard and Helen, and as well the webinar design team, which is displayed right on the screen. Next slide, please. With that being said as well, we're gonna be sharing the recording and the slides. These will be shared with all the attendees. We have the next webinar, which will coming in November, so please watch out for the announcements. And we also have a mailing list. If you would like to join our mailing list and be updated with some communication, you can do that. And you can also join the HPSR PASA listserv. And if you've missed previous webinars, please, you can go scan here or go into this link into your browser. You would be able to go to the YouTube channel of the School of Public Health, where all our previous webinars have been uploaded. With that being said, colleagues, thank you very much for spending your afternoon with us and learning together. Go well and God bless. Bye-bye.